Try to identify the following arrhythmias. Later on, we will discuss in details. Let us see the ECG graph. ECG graph has one small box 1 mm and one big box 5 mm. That means one big box contains 5 small boxes. ECG speed is 25 mm per second. That means 5 big boxes will be moving per second or 25 small boxes will be moving per second. So, one big box denotes 1 by 5 seconds. That means 0.2 seconds. Same way, one small box denotes 1 by 25 seconds or 0.04 seconds. A normal ECG has a P wave, a QRS complex, and a T wave. The P wave indicates atrial depolarization or atrial contraction. QRS complex indicates ventricular depolarization or ventricular contraction. And T wave indicates ventricular repolarization or the resting period. U wave indicates the Purkinje fiber repolarization. Now let us see the ECG leads. ECG has 6 chest leads and 6 limb leads. V1, V2, V3, V4, V5, V6 are the chest leads. Then the limb leads, 3 bipolar leads, 1, 2 and 3, and 3 augmented leads, AVR, AVL and AVF. Now let's see the 7 parameters for ECG interpretation. First one is rate, second is rhythm, then P wave, QRS complex, PR interval, PR relation and ST segment. Normal heart rate is 60 to 100. Below 60 is bradycardia and above 100 is tachycardia. Heart rate can be calculated by a formula 300 divided by number of big boxes in between RR interval or 1500 divided by number of small boxes in between RR interval. This can be done only for a regular ECG or regular rhythm. Then second point is rhythm. Rhythm should be, we will check regular or irregular. How we will see that? It should be in RR interval. RR interval same in all PQRS complex means that is regular rhythm. Next parameter is P wave. In P wave, we will look for its presence or absence. Then morphology of the P wave, we can identify some specific patterns. QRS complex, we will see it is wide or narrow. Wide means it is more than 0.12 second or 3 small boxes. Wide of QRS complex is indicating ventricular rhythm and narrow complexes will indicate it is atrial rhythm. In PR interval, we are observing the duration. The normal duration is 0.12 to 0.2 seconds. If it is prolonged or it is more than one big box or more than 0.2 seconds means it is a first degree AV block. PR relation, we will see the pattern P to QRS and QRS to P patterns. Specific patterns are seen in different AV blocks. The last parameter is ST segment. ST segment we will look for elevation or depression. ST depression indicates ischemic changes and ST elevation indicates myocardial infarction or MI. Different areas of heart will be affected and it will be denoted in different lead positions. Inferior wall MI indicates ST changes in lead 2, lead 3 and AVF. Septal ST elevation in V1, V2, anterior V3, V4 and lateral wall V5, V6, 1 AVR and AVL. Now let us go through the arrhythmias again and try to identify them using the key features and the parameters which we have already learned. Asystole. Here there is no P wave, no QRS complex. There is only one isometric line. This isometric line is the key feature for asystole. We have to follow the flat line protocol in case of straight line or isometric line. That are check the leads, change the leads and increase the amplitude. Increasing the amplitude will help us to differentiate between fine VF and asystole. Fine VF. Fine VF is characterized by no P wave, no defined QRS complex. The key feature is short and shallow fibrillatory waves, that shivering kind of waves. This is an irregular rhythm. Quash VF. There is no P wave, no defined QRS complex. The key feature is tall and deep fibrillatory waves. This is also an irregular rhythm. Polymorphic ventricular tachycardia. Features are P wave absent, wide QRS complex, and the key feature is multiple QRS morphology in that wide QRS complexes. You can see 2-3 sets of different kind of QRS complexes in this ECG. Torsades de Pointes. This is a special type of polymorphic ventricular tachycardia with special pattern. It is a spring-like pattern you can see in the picture. Prolonged QT interval and specific spring-like patterns are the key features for this kind of polymorphic tachycardia, that is Torsades de Pointes. Monomorphic ventricular tachycardia. Here you can see P wave is absent, wide and regular QRS complexes. Single pattern or uniform pattern or morphology in all QRS complexes you can see. So the key features are wide and regular QRS complex with a single pattern in monomorphic ventricular tachycardia. Supraventricular tachycardia. In this, P wave not detectable. P is hidden by T. Narrow QRS complex and regular rhythm. So comparing to the ventricular tachycardia, that is wide and here it is narrow. Very fast heart rate, usually above 160 or 180. So these all are the features for SVT or supraventricular tachycardia. Atrial flutter. Here flutter waves seen in between QRS complexes. Narrow QRS complex and regular rhythm. Sawtooth appearance of flutter waves are the specific feature for atrial flutter. Atrial fibrillation. Atrial fibrillation is an irregular rhythm. P waves are not well identified. Fibrillatory waves can be seen in between QRS complexes. Narrow QRS complexes are present. It is an irregular rhythm with irregular RR interval. Sinus tachycardia. Here the rate is above 100 beats per minute. P wave is present, QRS complex is narrow, PR interval is normal, and it is a regular rhythm. So here everything else is normal except the rate. Rate is higher than 100 beats per minute. Sinus bradycardia. Here we can see the rate is below 60. P wave present, QRS complex narrow, PR interval is normal, regular rhythm. So only the rate is below 60, everything else is normal in sinus bradycardia. First degree AV block. Here you can see P wave present, QRS complex is narrow and regular. PR interval is prolonged, that is a key feature. You can see the prolonged PR interval more than one big boxes, and it is prolonged in everywhere. So the key feature is prolonged PR interval in first degree AV block. Second degree AV block type 1. So here P wave is present, QRS complex is narrow. Here you can see progressive prolongation of PR interval. And after that a single non-conducted P wave can be found. So the PR interval is keep on increasing or prolonging. Then after that a single non-conducted P wave, and then the pattern will be repeated. So this is the feature of second degree type 1 AV block. Second degree AV block type 2. Here P waves are present, narrow QRS complexes. Here the PR interval is fixed in everywhere, but intermittent non-conducted P waves without progressive prolongation of PR interval we can see. So the main thing is intermittent non-conducted multiple P waves you can find, but there is no pattern, no specific pattern you can see. Third degree AV block or complete heart block. Here there is no PR relation you can find, and more P waves than QRS complex. So the key feature is no pattern or no relation between P wave and R wave, and there are many P waves than QRS complex you can find in complete heart block. Left bundle branch block and right bundle branch block. In left bundle branch block, you can see W pattern in V1 and M pattern in V6. In right bundle branch block, you can see M pattern in V1 and W pattern in V6. So you will remember this as LBBB as William and RBBB as Morrow. So the first and last letters denote the V1 and V6 for LBB and RBB. Myocardial infarction or MI. Here you can see ST elevation in different leads according to the affected area of heart. Inferior wall MI is characterized by ST elevation in lead 2, lead 3 and AVF. Septal wall, there is ST elevation in V1 and V2. Anterior wall is in V3 and V4. And lateral wall is in 1, AVR, AVL, V5 and V6. Second part and next topics on arrhythmia management as per ACLS protocol will be added soon. Please subscribe the channel for further updates. Thank you.